First of all, I'd like to thank the organizer and the chairperson to give me this opportunity to present my talk here. So today's my talk is physiology of Parkinson's disease. Before my talk, I would show you Japanese map. Just a moment. Let's point. Okay. So I'm from Tottori. So Tottori is a west part of Japan and a countryside of Japan. Now the aging population of Japan is increasing, especially in the countryside. So in Japan, the number of Parkinson's disease patients is increasing. Japanese population is about 125 million. The number of the patients with PD is about 150,000. Prevalence rate of PD is 100 to 150 per 100,000. Only in the population of older than 65 years, the prevalence rate became 1,000 per 100,000, much higher in elder people. So population of PD is not increasing only in Japan, but in all of the world. From the 1990 to 2015, the number of PD patients became twice in the world. It is called as Parkinson pandemic. So the total increase related with the increment of the elder people. So in most of Asian countries, population aging is occur. So the increment of patients with Parkinson's disease is a big challenge all over the world to clarify pathophysiology mechanism for Parkinsonian symptom is critical for future treatment of PD patient. So the Parkinson's disease shows the characteristic motor symptoms. First, bradykinesia or akinesia. It means the slowness of movement. Second is the tremor and the condition of rest with a frequency at the 4 to 5 hertz. Third, muscle rigidity. It's called the muscle hypertonus. And fourth, postural instability. So how do those symptoms generate it? So today's my talk is about the pathophysiological mechanism underlying Parkinson's symptom, mainly clinical basal ganglia cortical loop hypothesis. And I'd like to show how to detect the motor cortical excitability changes and the motor cortical plasticity changes. First, pathophysiological mechanism underlying Parkinson's symptom. This shows Alexander and Crutcher model of the basal ganglia thalamocortical loop. This is cortex, and this is the thalamus. So the thalamus, as a black line, means the facilitatory projection, and the gray one is the inhibitory projection. Thalamus is received the inhibitory projection from the internal globus pallidus. So there are two pathways between striatum and internal globus pallidus. The one is a direct pathway, and the second is an indirect pathway. So direct pathway inhibits the inhibitory projection from GPI to thalamus. So that causes the facilitates the thalamic activity. So this is a direct pathway. And in contrast, indirect pathway has a 3 inhibitory projection that causes the finally inhibited the thalamic activity. So the activation of thalamus are controlled by the balance between this facilitation and inhibition. The dopamine facilitated the direct pathway, and inhibits the indirect pathway. So in case of Parkinson's disease, dopamine neurons are generated, and the dopamine is decreased in the striatum. That causes the dopamine deficiency in the striatum. So that increase the indirect pathway activity and decrease the direct pathway. So both suppress the thalamic activation. It's induces suppression of cortical activity, and this cortical suppression could cause the bradykinesia. So this is a classic explanation for generation of bradykinesia. So dopamine deficiency in striatum causes a decreased activity in the thalamus, and this causes a decreased cortical excitability that causes bradykinesia. So now question is motor cortex always inhibited in PD, and as all symptoms explained by the motor cortical excitability changes. So I move to the second topic, how to detect the motor cortical excitability changes. So we can study cortical excitability using transcranial magnetic stimulation, TMS. TMS can activate motor cortical neuron non-invasively and induce the motor evoked potential in the hand muscle. So TMS activates the corticospinal neuron transsynaptically. That's because of this, we can know that we can use the MEP amplitude or as the cortical excitability. When the cortical excitability decreased, the MEP amplitude became decreased, and when the cortical excitability increased, so MEP size are enlarged. So therefore, we can use amplitude MEP as a parameter of motor cortical excitability. So I introduced short interval intracortical inhibition, SICI, using with paired pulse magnetic stimulation, first reported by Dr. Kujirai. So in this technique, both of conditioning and the test stimulus were given over the primary motor cortex through the same coil. Conditioning stimulus set at the subthreshold intensity, and the test stimulus evokes the MEP about 0.5 to 1.0 millivolt. So interstimulus between two stimuli set at the 1 to 5 milliseconds. So I show the representative MEP. So this is a test MEP. When conditioning stimuli proceeded to test stimulus at 1 to 5 milliseconds, the size of MEP decreased. So this called as the SICI. So this is a plot of this result. So x-axis is the interstimulus interval, and y-axis is a ratio of the MEP size. The conditioning MEP per test MEP. So from 1.5 milliseconds, the amplitude of MEP are decreased. So that's called SICI. From additional pharmacological studies, SICI is considered as a parameter of GABA-A receptor-mediated inhibition within primary motor cortex. So this is SICI in PD. The blue one is a healthy volunteer, I already shown. So, but in PD patient, SICI decreased comparing with a healthy volunteer. So that means excitability of motor cortex is not simply inhibited in PD. Cortical inhibitory interneural function is also decreased. Abnormal primary motor excitability modulation (EPD) may be produced by input lobe disturbed basal ganglia. Maybe cortical excitability modulation is abnormal in PD. So I move to the third topic. So how to detect the motor cortical plasticity changes in PD. So synaptic plasticity is neural ability to flexible changes, synaptic efficacy depending on presynaptic input characters. Synaptic plasticity plays a critical role in adaptation, learning, and memory. So when the synaptic efficacy increased, which called as the long-term potentiation, LTP, and decreased synaptic plasticity, called as a long-term depression, LTD. So LTP was first reported in the neuron of hippocampus. So EPSP of the hippocampus neuron was enlarged after the 1 Hz high frequency electrical stimulation. After the high frequency stimulation, so the EPSP is bigger and continuous, lasting for a long time, about 1 hour. So this phenomenon is named as LTP. So dopamine has an important role to induce the LTP. In PD, this kinase often appears after long-term levodopa intake. The PD patient shows sometimes non-motor symptoms such as impairment of motor learning or memory disturbance. So we think the reduced synaptic plasticity could relate it with these symptoms. So TMS can use as an intervention method for induction of cortical plasticity when TMS applies the brain repetitively. So there are several repetitive TMS protocols. Our group reported this quadrupulse stimulation using this special equipment. So quadrupulse stimulation consisted of a burst of 4 TMS repeated every 5 seconds for 30 minutes. So that's the 360 bursts applied. So when we change the interstimulus interval of 4 TMS, 1.5 to 100 milliseconds. So we applied QPS over the motor cortex and measure the MEP before and after QPS. So this is a result of the MEP changes after QPS. So depend on the interstimulus interval of 4 pulses, the after effect of QPS are changed. This means QPS, and before this means the ratio, and the x-axis means time after the QPS. So with a short interval, MEP size are enlarged, and with long interval QPS decreased. So the short interval with 5 milliseconds is most effective for LTP-like effect induction, and QPS with 50 milliseconds is induced to LTD-like effect. So we apply the QPS 5 to the PD patient. So we study the 16 PD patients with de novo or early stage PD patient and age-matched healthy volunteer. So this is the result of QPS. So this is similar. One is no changes. So green one is a healthy volunteer. So in healthy volunteer, so is a LTP-like effect or induced. And comparing with a healthy volunteer, Parkinson's disease without levodopa is the LTP-like effect decreased. But after levodopa intake, LTP was restored in PD. And in addition, the amount of LTP correlates with a clinical symptom. This figure shows the correlation between UPDRSA and MEP size after QPS. This shows negative correlation, especially with bradykinesia of contralateral arm. But it doesn't correlate with the cognitive scale such as MMSE or MoCA-J. So cortical plasticity is also impaired possibly due to the abnormal network of basal ganglia thalamocortical loop in PD. If so, the degree of cortical plasticity abnormality may be in parallel with that of clinical severity. So we summarize about the motor cortical plasticity in PD. LTP-like effect induced QPS was impaired in PD, and LTP induction was normalized by levodopa intake. The degree of motor cortical LTP may negatively relate with the severity of Parkinsonian symptom. So this is a summary of my talk. So there are several hypotheses for pathophysiological mechanism for PD symptom. One is dysfunction of the basal ganglia thalamocortical loop, which causes motor cortical excitability changes that we can detect with a paired pulse stimulation. And the second is changes of neural oscillation. I can't talk about this today because of time limitation, but this is related to with DPS efficacy. And the third is a disturbance of neural plasticity. So we can also detect in the human using the QPS. So we can detect some of these physiological changes in PD non-invasively using TMS techniques. So this shows the collaborator of this study. And thank you for your attention.